Hello, my name is Rudy Nunez, and I am a PharmD candidate, class of 2024. I study at California North State University College of Pharmacy in Elk Grove. This is my drug information presentation on the drug Devalproex. Its generic name is Depakote. So Depakote is known as an anticonvulsant anti-manic agent. It comes in various different formulations. The oral tablets come in ER and DR formulations. Extended release is a 24-hour tablet. It comes in 250 and 500 milligrams. The delayed release, it says it's a delayed release, but as soon as it's released, it becomes immediate release. So it will have a higher frequency throughout the day, usually twice a day. It comes in 125, 250, or 500 milligrams. There are also oral capsules that come in the delayed release sprinkles, 125 milligrams. The oral solution comes in 250 milligrams per 5 mLs, and the IV solution in 500 per 5 mLs. Depakote should not be mistaken by Depakine, which is just valproic acid. Divalproex is a combination of valproic acid and derivatives. In terms of pharmacokinetics, we do like to describe the ADME processes in terms of absorption. This medication is 89% bioavailable, and food has no effect on absorption. In terms of distribution, this medication has a volume of distribution of 11, which is a relatively small volume of distribution, which means the medication stays in blood plasma concentrations. It does also have 88 to 90% protein bound. In metabolism, this medication is extensively hepatically metabolized, and there you will notice that it does have some major and minor substrate CYP interactions. In terms of elimination, it is renally eliminated 30 to 50% and has a half-life of 9 to 16 hours in adults. So for its mechanism of action, Depakote can cause an increase in availability of GABA, which is an inhibitory neurotransmitter. It also blocks the voltage-dependent sodium channels, which result in suppression of high-frequency repetitive neuronal firing. So this results in better control of seizures and mood disorders. Valproic sodium is a compound of sodium valproate and valproic acid, and once it is administered, it dissociates to valproate in the GI tract. So its serum levels will be monitored based on valproic acid in the system. This next slide lists the indications, dosing, and titrations for Depakote. Absent seizures, we're going to start with PO 15 milligrams per kilogram per day, and then we can titrate to the max dose of 60 milligrams per kilogram per day. For complex partial epileptic seizures, we can start with 10 or 15 milligrams per kilogram per day, and then titrate to 60 milligrams per kilogram per day. For bipolar disorder, it's a slightly higher dose. We could start with 20 to 30 milligrams per kilogram per day, and then titrate again to the max of 60 milligrams per kilogram per day. We could also initiate 500 or 750 milligrams per day, and then increase by 250 to 500 every 1 to 3 days. For migraine prophylaxis, we could start with the extended release 24-hour tablets, 500 milligrams daily for 1 week, then 1 gram daily thereafter. The delayed release, we initiate with 250 milligrams by mouth twice daily, and then we get increased to 500 milligrams by mouth twice daily. Some of the warnings and precautions associated with Devalproex include black box warnings for hepatotoxicity. This includes fatalities that have been reported, usually in the first 6 months. We have pancreatitis, fatal hemorrhagic cases have been reported. We also have fetal risk or neural tube defects. Some of the contraindications, of course, hypersensitivity to Devalproex would make it contraindicated for that specific patient. Also with patients who have severe hepatic disease or urea cycle disorders. We are going to avoid it in hepatic or severe hepatic dysfunction, and we're going to avoid it in pregnancy. It is contraindicated in pregnancy prophylaxis with migraine, but in some cases we can use it in pregnant women but in the next slide, we're going to go deeper into detail in that regard. Depakote is of major concern in women who are pregnant because of the risk for congenital malformations, particularly neural tube defects, such as spinal bifida. Valproic acid should not be used to treat women who are pregnant with epilepsy or bipolar disorder unless other medications have failed to provide adequate symptom control. This is, of course, a discussion between the provider and the patient, and they really have to weigh out the risk and benefit. And of course, they would be counseled to continue taking folic acid to try to prevent some of those risks. Another takeaway point here is to also say that before starting a woman who is of reproductive age, they should also be counseled to continue on with effective contraception. For monitoring parameters, we also have to look at serum levels. Some experts suggest checking serum levels 1 to 2 weeks after their initial dose to help guide for dose adjustment. The therapeutic range for epilepsy is between 50 to 100 micrograms per liter, and the therapeutic range for acute mania is between 50 to 125 micrograms per liter. We are also going to counsel provider and patient to make sure they know that they're going to be monitored for their liver function test, ammonia levels, complete blood cell counts, and platelet levels. Efficacy monitoring, of course, is going to be the reduction of seizures, the control of mania, and or the reduction of migraine and severity. In terms of side effects, we do have our common side effects that happen in about 10% or more of the population. We have nausea, vomiting, diarrhea, abdominal pain, alopecia, hair loss, diplopia, double vision, dizziness, headache, somnolence, and tremors. Less common side effects, which happen in 1 to 10% of patients: blurry vision, nervousness, hyperammonia, indigestion, infection, insomnia, loss of appetite, rash, and weight gain. In the rare, which happen in less than 1% of patients: hepatitis, palpitations, pancreatitis, tachycardia, thrombocytopenia, and suicidal ideation or behavior. The toxicity monitoring parameters include signs and symptoms of peripheral edema, increased heart rate, weight changes, and pancreatitis. Pancreatitis can be seen as abdominal pain, nausea, vomiting, or emergence of depression, suicidal ideation, or unusual changes in behavior. So remembering that Depakote is extensively hepatically metabolized, we're not surprised to see a list of medications that have drug-drug interactions with it. So typically you would kind of predict that anything that gets processed by the CYP enzymes would have some sort of interaction with Depakote. Here are a list of a few of the medications that do have interactions and how to monitor those interactions. With a patient taking aspirin or macrolides, we're going to see an increased level of Depakote concentrations, and in that case we're just going to have to monitor valproic acid levels a little more closely. For a patient taking carbamazepine, ethosuximide, lamotrigine, roflumilast, or any of the tricyclic antidepressants, those medications actually get inhibited by Depakote, so there's going to be an inhibition of their metabolism. So we're going to start with slower titrations of Depakote. We're going to monitor levels a little more closely. We're going to lower doses of lamotrigine. With acyclovir, carbapenems, and protease inhibitors, those medications actually decrease Depakote concentrations, rendering it possibly ineffective, and so we're going to just avoid that combination altogether. For phenytoin and phenobarbital, we're going to see altered levels of Depakote, and in that case we're going to monitor valproic acid levels. In terms of warfarin actually gets displaced by Depakote, which can thus lead into an increase in warfarin's effect or increase in bleeding risk. So we're going to monitor the INR. And for topiramate, we're going to potentially see an increase in hyperammonia. And in that case, we're going to monitor hyperthermia and encephalopathy symptoms. Some of the discontinuation of therapy processes for valproic acid, it should be withdrawn gradually over ideally over 2 to 6 months, to minimize the potential of increased seizure frequency and or withdrawal symptoms. In patients discontinuation therapy for treatment of bipolar disorder, we're going to have to monitor closely for several weeks or months for reemergence of mania and hypomania occurrences. And with this slide, I would like to wrap up my presentation and give you a list of the clinical pearls, which are the take-home points for you as you go. Depakote can be used to treat seizures, bipolar disorder, and migraines. It also has multiple formulations that are available, but these formulations are not always interchangeable. Safety and efficacy in children younger than 10 years old has not been established. Devalprex is teratogenic and should be used with extreme caution in women of childbearing age, and specifically in women who are pregnant. Depakote is extensively hepatically metabolized and thus will have many drug-drug interactions. And listed here are my resources for this presentation. Thank you once again for your time and attention.